says, you know, I got my baby back. This is the thing is, how do we find a way to help a person sort of reconsolidate themselves into who they are and find their way back to that home? So we know that architecture is dependent on the raw materials used to build it, and by the time we're 5 years old, 90% of our infrastructure neurologically has been laid down. So, just to say, we live in America where Pop-Tarts are presented as part of a balanced breakfast, and they are not. And we make crappy brain structures from Pop-Tarts, in case anybody has any question about that. We also know that any kind of injury, damage, pressure, anything that changes that internal milieu of your brain also changes the remodeling capacity of the brain. So when we talk about autologous therapies, really what we're talking about is a reallocation of resources from one area of the body to another area of the body. One of our consistent sort of questions is, well, if this stuff was already in me, how come it didn't mobilize and go fix whatever the problem was? Well, because at the time of acute trauma, a body's busily dealing with a lot of that was acute trauma messengers, as well as initial blood flow and healing. As time goes by and you move into a more chronic state, which could be 6 weeks after your initial injury, now a body becomes complacent. It doesn't necessarily mobilize the same resources into those areas because there's not the same acute trauma messengers. Autologous therapies have been around for a very long time, at least 100 years in terms of blood therapies, but we find reference in the Shraka Samhita as of 2,000 years ago, an Ayurvedic textbook where they were doing skin grafts to repair a nose. So we know that some part of autologous therapies are at least that long, and essentially all we're saying is we're taking something from one part of your body and we're moving it to another part of your body. Some examples are plasma, different platelets. Platelets are fairly straightforward. You can get those from the peripheral blood draw, which we will talk about. Bone marrow, lymphocytes, urine. Turns out the Porter John Company has a brisk business in selling imidazole urea to pharmaceutical companies. That stuff that makes your skin soft, construction worker urine. Who knew? Skin hair club for men. Yeah, you can transplant your own hair from your back to your head. I'm not sure how that looks, but you can do it. Platelet-rich plasma is one of the initial autologous therapies, at least that we deal with primarily. In PRP, originally we used it as a way of helping athletes recover certain joints, right? PRP is basically you're getting a 5-pound greater amount of platelets in your sample, you're administering those platelets. Initially, you're trying to get an inflammatory effect to get that tissue to heal again, more appropriately than it did, say, the first time that was damaged. What we have found is you can adjust the amount of platelets, you can adjust the other factors within that sample so that you can have a much different effect in the body. And so one of the questions that gets begged is, what makes something a PRP? Well, basically a PRP is just a platelet-rich plasma. You're capitalizing on the fact that platelets are your drivers of inflammation, and you're also capitalizing on the fact that they are very rich sources of a growth factor called platelet-derived growth factor, which ends up being a really good driver of remodeling response in the nervous system. So basically, PRP is a crude separation technique. If you want to do it well, you spend a little extra and you get a programmable centrifuge so that you can dictate exactly how you're going to spin that sample, so that you can look at how your layers come out. We use 50 mil Falcon tubes, and you'd be amazed at how just a set of cell sieves at a certain size and a good programmable centrifuge can help you isolate some really tight layers of tissues from a sample. We really heavily focus on white blood cells, which is not something that's usually done with PRP. But we find that CD4 cells, especially as a T lymphocyte, is a helpful agent in initiating remodeling processes. There's a company out of Germany called Pluriselect. They will sell you little acrylic beads that are pre-embedded with T lymphocyte receptors. You can harvest from a blood sample. You can harvest whatever T lymphocyte you want that they have a receptor site for, simply by incubating your sample with the beads, rinsing away the rest of the sample, and then rinsing away the antibody or the white blood cells that have attached themselves to the beads. Once you get this little buffy coat, which is the white layer that's on the picture there, which my little thing isn't working, but it's okay. So essentially, we use platelet-rich plasma originally for musculoskeletal injuries. You're taking an area that didn't heal well or isn't healing well, and you're stimulating a better healing response. Early on, we started using this for some patients with traumatic brain injuries, mostly because of incidental findings where we were doing a treatment on somebody, several people in fact, where we found that their neurologic symptoms were improving as we were doing PRP, say in a shoulder joint. We're not even doing anything with the brain specifically, we're just putting it into the joint. And we're seeing some pretty remarkable changes in their neurological recovery. And then we started putting some intranasally, and what we found was that really changed the game. And so we'll talk a little bit more about that as we go. What's in PRP? Well, a whole bunch of stuff. And if you're a 3-year-old, and I just pulled a blood sample from you, I get a whole bunch of different constituents than if you're a 30-year-old, and I just pulled a PRP. Kids are little growth hormone factories. And they've got a lot of really interesting things in their blood that facilitates healing in their system. And again, we're just reallocating a resource to a different place in the body. And so there are a number of growth factors. This list is adults. And kids, you could expand that pretty tremendously. From PRP, we talk about stem cells. So let me just say the FDA says, if you use the word stem cells, you are lying. That's what the FDA says. They think that any reference to stem cells is a misrepresentation. I'm not sure that they're wrong. I was at the grocery store the other day, and next door to the grocery store is like a little CBD strip mall kind of a place, you know. They've got a little apron placard out front. It says, "We have stem cells." I'm like, I'm pretty sure you don't, but okay. You can go get shampoo and it says, "Oh, apple stem cells in this shampoo." Okay, we just call that an apple. You can eat that. It's probably not going to do much for your hair. CBD stem cells, probably not going to do much for you. It's become such a marketing term. Here's what you should know. There are really only 2 kinds of stem cells that any one of us should be concerned with. Ours and somebody else's. So, within your own body, by the way, if you take some cells from you and you put them back in you, how much rejection do you get? Just about 0. If you take some cells from your neighbor and put them into you, how does that go? Well, you're going to have anywhere from a 30% rejection rate to a 100% rejection rate for those cells. That's important because there's a lot of products in the market that will make a lot of claims about how you're going to have somebody's useful stem cells. Okay, I'll eat those up too. That's what a body does with foreign material. It doesn't matter if you call it an exosome. If it came from another person, it's not you. So what your rejection is going to look like is going to be variable depending on who those donors were. How those donors get screened. Currently, we don't screen donors that well. We got a Chagas problem. You know Chagas? Chagas is a schistosomiasis infection from South America. We have that problem in our blood supply now. We didn't know we should screen for that. That's how HIV came to our awareness. That's how HCV came to our awareness. We had contaminated blood supplies. We don't have a great proactive way to screen donors for tissues that we're going to give to people who are in a complex medical situation and damaged. Within your body, you've got a lot of stem cells that have a lot of potential. We call them embryonic in adults. Embryonic came from someone else. Doesn't matter if that someone else is 8 weeks into gestation or that someone else is 35. It's still someone else's tissue. You're going to still reject it, whether it's embryonic or not. You can get stem cells from bone marrow. We do that frequently for people that have multiple myelomas that need bone marrow transplants or other kind of leukemic conditions. That's how we started. I started doing bone marrow extractions and lumbar punctures to re-administer the material. And let me tell you, that's a stressful day at the office because you can't numb up a bone before you go in and get a bone marrow biopsy. and you use this little corkscrew trocar that comes in, and it's hard. You have to put people to sleep for that. I don't like taking people who have neurologic damage and controlling, engaging in a controlled poisoning process so that I can do a procedure on them, right? Anesthesia's not good for your brain either. Truth is, stem cells, even though theoretically they can become any cell in the body, we note that there is a definite strong proclivity between mesenchymally derived and hematopoietically derived stem cells. When you pull them out of bone marrow, those cells have a greater tendency to become other bone marrow products, blood products, white blood cells, red blood cells, platelets. They can become connective tissue, but there's a lot more involved in them becoming that. Versus if you drive those cells from connective tissue, then they become your target much more rapidly. So there is a difference between how bone marrow cells respond and how adipose-derived cells respond. We do adipose-derived cells for a couple of reasons. When we were doing bone marrow biopsies, a good day we'd pull a 600,000 cell sample. 600,000 cells in the US is all you get. In other places in the world, you can expand those cells. In the US, you can't expand them because they haven't made a new drug. So we have to take what we get. The first time I did a fat biopsy, I got 4.5 million cells, and I didn't even know what I was doing, really. So now we generally don't get less than 300 million cells when we do about a 5-gram biopsy. And that's largely because of some work that we'll talk about by a woman named Patricia Zook, who wrote a monumental paper that sort of blew the lid off of this whole process in 2001. So you have some stem cells floating around your peripheral bloodstream. Monocytes basically have the capacity to be de facto stem cells. You have not very many, but they still are there. If you want to expand them, you can get them. Bone marrow, adipose tissue. Adipose tissue has the added benefit too, in that it is able to be numbed up. I can put, like with kids, here again, your 3-year-old who had a near fatal drowning, I could put a topical gel on and a spray, and about 3 applications of each of those, which the topical gel and the spray generally are bupivacaine, lidocaine, tetracaine, your kind of classic BLT sort of a mixture, so that you get nice topical anesthesia. Then I go in with a combination of lidocaine and procaine in order to numb the area more effectively, deeper in before I go and take a sample. A lot of this was spawned by Patricia Zook in this particular paper, and where she showed that, hey, there's 50 to 75 million stem cells per gram of fat. That's a mother load. That fat we refer to as the stromal-vascular fraction. So essentially, you're doing a in-office liposuction. You numb the person up. We have a special device made by a company called Tulip out of San Diego. They do mostly cosmetic procedural tools, and they make a face liposuction kit, which works really great for kids. Generally, we numb them up right off the love handle, and we take our sample. I'm going to show you a picture that actually isn't very good, but I'm going to describe that. In 2015, myself and a group of other members of the International Stem Cell Coalition pooled a lot of data, and we published this particular paper. In this paper, we had 156 joints, 1,114 patients, and we were able to follow them from anywhere from at least a year up to, well, some of the patients were still following, honestly, we still see them. And we found that it was about a 91% effectiveness, depending on how we applied that particular cells for regeneration of joints. So adipose is great because it's pretty easy to harvest. Most people have plenty. All you have to say is liposuction, and you've got a room full of volunteers. Pick me, pick me, pick me. We have to establish that, is there really cells in adipose tissue that would act like a mesenchymal stem cell? And the answer is yeah, absolutely. In fact, there's quite a few of them, and if you work your extraction process well, you can access a majority of those. And adipose tissue-derived cells have been shown to become just about any tissue you would like. including, in some cases, some blood products, but really, that's not their proclivity, right? That's where hematopoietic stem cells come in. Our particular area of interest is, of course, neuronal function. So here's the picture that's in the back picture. It's a bad picture because the way the artist rendered the extraction process isn't quite right. So essentially what you're doing is you're going from medial to lateral. I'm numbing up the area right above the sacroforamen, and then I'm coming out across the iliac crest. Generally, there's a pretty good fat sample there. Also, there's nothing majorly important in that area, so that if you're doing an extraction, you're not going to hurt anything. It's also kind of out of the way, so it's not an area that constantly hurts after you've done the procedure. So, when I put the numbing gel on, and when I put the numbing material inside the procaine and lidocaine, I'm doing it at the place of the sacroforamen because that's where I put my sample back in, and I want it to still be numb when I go to put that sample in, so I don't have to put any more anesthetic in. There's a lot about why I choose the anesthetics that we choose. By the way, we are a compound practice, so that means we make everything. We make everything from scratch. We have to be extremely mindful of quality control, and in the industry of pharmaceutical production isn't very great for that. I don't like preservatives in my anesthetics, because that's where a lot of people have their reactions. And so procaine, it turns out, is a great vasodilator. It breaks down into PABA and DMAE, and both of those improve blood flow into the synapse. So procaine is a great neurotransmitter to use for neurological conditions. So we suck some fat out of the person. Not the way the picture shows, because that would be problematic, but rather lateral from sacroforamen area out laterally across the iliac crest. We get a sample of fat. Initially, we're extruding it. I'm putting it through a lunar lock to lunar lock adapter, through 2 syringes, and we're essentially just breaking up that connective tissue. We take that material, we put it into a Falcon tube. That Falcon tube, we start spinning. We spin at different rates depending on what we want to accomplish and what we have, how the sample looks. Generally, we're starting at 1,300 RPMs. That's related to the radius of the arms and centrifuge. You're looking for a particular G-force. Generally, the amount of the sample is about 3.5 to 5 grams. That's, depending on the person, fat is, can be really dense, it can be soft and buttery, so you've kind of got to compensate for that in your mind when you're taking the sample. Once you break up that adipose tissue through the extrusion process, you start separating. Now, depending on the size of the material you have, you might have some chunky connective tissue, you might have to run that through a cell sieve. Cell sieves come in different sizes. Here again, Pluri Select is a company that we use quite a lot, and they make a really nice array of different sized cell sieves. Once I get the cells isolated, then I put them on a Hume cytometer and we do a count so that we know what did we get. Part of that is also we use a stain called tripad blue to make sure that none of the cells die in the process. That's my goat. His name is Twister. So there's a lot of good reasons why we like adipose-derived tissues. Plus, most people have a lot of adipose tissues. The components are a little different than they are with PRP. So often, especially in adults, we will mix a PRP in with the stromal vascular fraction just to get the best of both worlds. And a number of these proteins end up having really great other effects. One of those is the first one on your list here, which is thymosin beta 4. Your thymusins are thymic proteins. Their job is to mature an immune response. Part of that job is to weed out autoreactive antibodies. PB4 in particular, not only does it help refine an immune response, but it also is a heavy inducer of actin filaments being laid down in muscle tissues. So when people have dystonia and they've lost a lot of their muscle mass, and they're just wiry bands, TB4 will help give you some expansion there, some volume to those tissues, which is important when we talk about what we talk about next. These are actual pictures of some samples that we took at the clinic. We've got a neuromicroscope that I think is a little better resolution at this point in time. This is a standard Neubauer hematocytometer. This is what you would use for any cell count that you would do anywhere. When we do the transplantation process, generally, I do that in at least two ways. First off, about 10% of our sample gets done intranasally. In order to do that intranasal administration, you've got to prep the patient with some hyaluronidase and some collagenase. The two enzymes that break up connective tissue, they allow a couple of things to happen. We're doing this before we're actually putting cells in intranasally. As the enzymes come in, they're very, very specific. Collagenase breaks up some collagen, hyaluronidase breaks up hyaluronan or hyaluronic acid. That creates a path across the cribriform plate through the nasal passageway up into the brain. Specifically, you're following the path of trigeminal nerve, ultimately, if you're going to get all the way in. Part of that is when I put the cells in, stem cells, mesenchymal cells, are driven by trauma. That's what they're made for, right? They're sitting in your fat, they're waiting for you to get rolled by a bear, so